All right, so yes, thank you everybody for hopping on. Looks like we have a great group. So really looking forward to hearing the discussion today. But so like I said at the beginning, this talk is co-hosted by the MHTTC, so the New England Mental Health Technology Transfer Center, and MAPNet, so the Massachusetts Psychosis Network for Early Treatment. For our MAPNet clinicians, welcome, and for people who are coming on for the MHTTC call, we're happy to have you. I'll just point out at the beginning that we are offering CEUs for this talk. So you'll receive an email at the end with information on how to get those if you're interested. And Kesh, if you can just go on to the next slide. So you'll notice that you're all muted on entry, but you'll be able to unmute yourself during the discussion portion. And like Margaret said, it would be great to hear who you are and where you're coming in from. But please feel free to use the chat box to introduce yourself, and also let us know if you have any technical problems or questions throughout the talk. So we really want this to be as participatory as possible. And so one more thing that you'll notice, this session is being recorded, so it will be available for you to view afterwards. So we have an information here on how to reach us after the talk. So it's newengland@mhttcnetwork.org. So feel free to send any questions specific to this talk or otherwise, and we'll get back to you through that. So if you can go on to the next slide. We just have a disclaimer here. Basically, this talk is being funded by SAMHSA and the Substance Abuse and Mental Health Services Administration. And everything here is in the public domain. We want people to be able to see it and access it. And again, you'll be able to find it online afterwards. And then the next slide. And again, because this is going to be an open conversation, I just want to set the stage that there are a lot of things on here, but all of it comes down to having an open, respectful, strengths-based conversation. So I have no worries about our group with that, but I just want to put that out there at the beginning as well. So with all of that, so this talk is going to be on a project that Dr. Keshavan and Raquel Meshlam-Gately worked on as a part of our group here on the idea of renaming schizophrenia. Just an introduction of both of them. Dr. Keshavan is the Stanley Cobb Professor of Psychiatry at Beth Israel and Harvard Medical School. He is also the academic head of the psychiatry department and the director of this BIDMC site for the New England MHTTC, as well as a board certified psychiatrist. So he's been closely involved in research in neurobiology of psychosis, and is also the editor-in-chief of schizophrenia research. And then Dr. Raquel Meshlam-Gately is an assistant professor of psychology in the Department of Psychiatry here at Beth Israel and at Harvard Medical School. She is also a licensed clinical psychologist and a neuropsychologist who directs the Consumer Advisory Board and the neuropsychology research at the Psychosis Research Program here at Beth Israel. So she is the co-director of our site for the New England MHTTC as well, along with Dr. Keshavan. And we also have some members of this Consumer Advisory Board joining us, but Raquel will introduce them shortly. So I know that was a lot of information, but Raquel, if you want to start off the talk by going over what we'll be talking about.
Absolutely. Thank you so much, Kelsey, for that introduction. And good morning. Welcome, everyone. We have a packed agenda today, as you could see. So I'm just going to jump right in and pose to all of you our central question. Are we ready for a name change for schizophrenia? So I don't want you to respond verbally, at least not yet. Initially, we would love for you to answer that and some related questions through an anonymous pop-up survey that's going to be appearing on your screen now, if we can make that happen. This is part one of a survey we'll be telling you more about shortly. Part two will appear later on in the presentation. We'd like you to complete part one now so we can capture your thoughts before we provide any further description of alternate names for schizophrenia, both through our presentation and within part two of the survey. And please don't worry about filling this out while I continue speaking. I'm sure you're all great multitaskers and you can listen while completing the survey. And besides, I won't be able to tell if you're not anyway, because this is on Zoom. So we really do want your opinion. So just if you can fill out that poll, that would be great. And just so you know, our survey is going to be divided into a few polls that will be popping up just because of Zoom constraints. We had to split it up a little bit. So we'll pause between each section of it. So you can see on the slide behind the poll, there's an outline of everything that we're hoping to cover today. So this survey, then we'll get into a rationale for name change and renaming efforts around the world. Then we'll be doing part two of the survey and just reviewing some feedback about that. And we'll be describing the Consumer Advisory Board and findings from our Renaming Schizophrenia survey project, some implications for how to talk to people with early psychosis, and then we'll hear some reflections from Consumer Advisory Board members and open it up for comments and discussion at the end. So let's see if we have some results from the initial poll. Okay, great. Trying to scroll through this. Okay. And in looking through this, as you'll hear later, it looks like a really nice, diverse stakeholder representation, very similar to what we found in our survey project. So Vanessa, if you can pull up the next part of the survey for everyone to complete, that would be great. Give you all a little time to work on that.
I'm sorry, I just have a quick question. Is the part two just the one question?
Yeah, right now you should just see one question and then there'll be a few others appearing momentarily. Just want to give everyone enough time to respond to this. Okay, great. And then Vanessa, can you pull up the next part? Again, this is pretty consistent with what we found in our survey. So these are potential alternate names for schizophrenia, and we'd like you to rate how much you like these alternate names. Vanessa, is this poll active? It looks like nothing is being captured here. Oh, working now. So we'll give everyone a minute or so to complete this. Okay, we'll give it another 30 seconds or so. Okay, why don't we stop the poll here? Really interesting. Let's see where everybody falls on how favorable these names are rated. Again, pretty consistent with what we saw in our survey. And then Vanessa, I think there's one more part to this before we move on to the next section of the presentation. Okay, so everyone could just answer this question too. Great. Okay, I think we can close out the poll. I think it's pretty clear how most people who took this feel about the term schizophrenia. And we're going to come back to all of this a little later on in the presentation, but thank you for sharing your opinions to begin with. And with that, I want to turn it over to Dr. Keshavan to share his expertise regarding renaming efforts around the world, as well as the rationale for a name change. Kesh?
Okay. Yeah, thank you, Raquel. That was a very good introduction to the topic of today. And I'm particularly delighted that we are co-sponsoring this between the MHTTC, which is an initiative by the SAMHSA to improve care for and capacity building for serious mental illness, and our own Massachusetts Psychosis Network, which is a DMH-supported consortium for capacity building and training for early course psychoses. The reason it's important for both of these organizations is that we need to, think through carefully about how we conceptualize this term, which we call schizophrenia, in our terminology for how to talk to our patients. And also the fact that the first time we will be talking about diagnosis in a given individual's life is in around the first psychotic episode, which is what MAPNet's overall mission is, to improve care for people in the early course of their illness, that we improve the overall trajectory of the course of their illness and their lives. And so this is very important for us to think about, to provide care in a way that is recovery oriented and non-stigmatizing, and at the same time evidence-based and effective. So let's think through the historical aspects of the name, how schizophrenia came about, and other psychiatric disorders. As you all know, schizophrenia is not the first name for this illness. It was called dementia praecox by Emil Kraepelin, who is considered the father of modern psychiatry over 100 years ago. And this term, dementia praecox, was given up in the early part of the 20th century when Eugene Bleuler coined the term schizophrenia. At that time, his explanation for this was that this is a disease with a split mind between cognition and affect, and between different aspects of the thought process and so on. But the term schizophrenia has also been a matter of continuing debate and has over the years carried a lot of confusion and stigma. My goal in the next few slides is to give you an overview of what we currently think about this terminology and the evidence for and against the use of this term schizophrenia, and I'll have you make up your minds. I'm not here to sell you the idea that this name has to be given up, or that something has to be changed and so on. But you make up your minds, and I'm going to tell you what we think from the scientific world. And after I say from the scientific world, you will have some input from our own consumer advisory board as to how people with lived experience of these illnesses are experiencing about this. And I'm hoping that Ellen Sachs, who is in this meeting, will also be able to say something at the end from her own point of view. So, as I said, the last 50 years of research has clearly shown that what we now call as schizophrenia is probably not one disorder. At least several groups, including our own group, have shown that this is a heterogeneous illness with multiple syndromes. There is no one person with schizophrenia who has the same kind of clinical picture as another person with schizophrenia. There are so many differences. So for this reason, there has been a progressively increasing viewpoint that the condition we call schizophrenia should be reconceptualized as a part of a spectrum of psychosis. This is not such a new idea, actually, because Eugene Bleuler in 1911 himself had stated, he did not say schizophrenia as one disease. He called it the Gruppe der Schizophrenia. So group of schizophrenias is what he called. But the rest of the field did not exactly listen to what he was saying and continue to use the term schizophrenia, which continues to be a disease entity within the DSM even to this day. Now, the idea of reconsidering names of psychiatric illnesses is not unique to schizophrenia. Manic depression, for example, in the 1960s was changed to bipolar disorder. Mental retardation was renamed to intellectual disability, and so on. So as we learn more about these illnesses, we have to think about what we name them. It's very important. Now, why rename schizophrenia? One important factor that has been instrumental in people thinking about a renaming of this illness is the stigma that is attached to this illness, and also the misconception and confusion that exists around what exactly it means. Schizophrenia often is used not as a noun, but as an adjective. We did a study some years ago where we looked at Twitter, the terms schizophrenia and schizophrenic as they appeared in Twitter, and compared the positivity or negativity or sarcasm and the appropriateness versus inappropriateness of these terms between diabetes and schizophrenia. People use the word diabetic as well. In describing individuals with this illness, and people sometimes use the word schizophrenic when describing individuals with this illness and so on. But what we found was that the term schizophrenic as an adjective was a lot more used in that way as an adjective compared to diabetes. So as you see in this slide, sarcasm and negativity, inappropriateness, they were all particularly more common when the term schizophrenic was used as an adjective as opposed to schizophrenia as an illness. But both these situations, all of these negative connotations were more with schizophrenia than with diabetes. In diabetes, it didn't matter as much whether you called it diabetes or diabetic. So the use of the term as an adjective is a significant problem that we have. And also, part of the reason why we continue to have this debate and this increasing urge around the world that is emerging to change the name is because we don't know what schizophrenia is. As this cartoon shows, Going back over 100 years ago, we had theories that schizophrenia is caused by parents. So it's the schizophrenogenic mother was one of the theories. And then there came at a point when people talked about a schizophrenogenic grandmother even. These were the days of the psychoanalysis. Fortunately, over the last half century, there has been no evidence that has emerged that parental upbringing has anything to do with the emergence of this illness. And in the 1980s and 70s, there was another force which is often called anti-psychiatry. Like Thomas Szasz was one example, a psychiatrist who almost dismissed the idea of schizophrenia being an illness altogether. And he said it is a sane response to an insane world. I'm sorry, that's Thomas Szasz. And whereas R.D. Laing said schizophrenia is not an illness, it's a spiritual breakthrough. It's not a nervous breakdown, it's a spiritual breakthrough and so on. So again, there has been not much of traction thankfully, for these kinds of viewpoints. Some other theories which have been there for over half a century or even a century, one of the theories is that schizophrenia is a developmental disorder, brain developmental disorder. This is actually not new. It goes back over 100 years ago. And one of the psychiatrists at the very institution that I'm speaking from, Massachusetts Mental Health Center, by name Southard, he was instrumental in developing this idea that schizophrenia is a developmental disorder. And over the last century, there has been increasing evidence that indeed there is a dysfunction in how the brain develops during the period of adolescence that might underlie this illness. And dopamine, we all grew up learning that dopamine is central to this illness. All the treatments that we now have, all the antipsychotic medications, they work via blocking dopamine. And so the theory has been that schizophrenia is due to too much dopamine in the brain. So these two theories, that schizophrenia is a developmental disorder and it's a dopamine disorder, those two theories have not gone away. But we still do not know for certain that this illness can be explained by brain development and by dopamine alone. So it's too complex a condition to be explained by any one of these hypotheses. So because of these two reasons, namely the stigma and also the lack of understanding of what exactly this disease entails, there has been a pressure building around the world to rename this illness. For example, in Japan, the former name, which was similar to schizophrenia, which was a mind split disease, Seishin Bunratsu Bio, I hope I'm pronouncing it right, was renamed to Togo Shicho Sho. It was found through some number of papers fairly soon after this name change happened in the early 2000s, that number one, the association between the term for this illness and criminality went down. And also, more number of doctors and clinicians were talking to patients about the diagnosis after the name change as opposed to before the name change. Also, there was more of a endorsement of a biopsychosocial cause and less of a attribution of dangerousness, and also social distance. A reduction of social distance got better after the name change, and reduced negative views in the press after renaming. Similar trends happened in South Korea, where it was named as attunement disorder. Again, I don't know whether my pronunciation is correct. It is Yohyeon Byung. Studies showed that it significantly reduced prejudice and stigma compared to the previous disease, which was split brain disease. In Taiwan and Hong Kong, the name was changed to disordered thought and perception. Even though the results of reduced negativity, which was seen with the other name changes, has not been as clear-cut with Taiwan and Hong Kong. Very quickly, why these terms, attunement disorder, integration disorder, how did they even come about? Now, when they say attunement disorder, that is the implication is that the brain networks, the neuronal networks are not in tune with each other, which is, in many ways true and supported by, current day neurobiological research evidence. But in any case, it was found that after the diagnostic nomenclature change, as you see here, psychiatrists, compared to 68% before renaming, 88% of them, or 89% of them, talked to patients about their diagnosis. So did psychiatry residents. The change was not as prominent with nurses and psychologists, but social workers also increased in the frequency with which they talk to patients about their diagnosis. Now, a number of alternatives have been proposed for this term schizophrenia, which includes Kraepelin's disease. I mentioned to you Kraepelin as the first person who coined the term dementia praecox. Salience syndrome, which was coined by Jim Van Os. Psychosis susceptibility syndrome, which was a term that was proposed by George Clea. Neuro-emotional integration disorder by Levin. Bloiler syndrome by Henderson and Nash. And we had proposed a name called Concord syndrome because the three key aspects of this illness that are impaired are cognition, reality testing, and the term conation, which means behavior. We ourselves did not think that this would stick because people won't know what is meant by conation. It's too technical a term. Psychosis spectrum disorder, again, Jim Van Os proposed that. Dopamine dysregulation disorder has been proposed. And altered perception syndrome, one of our own consumer advisory board members suggested this name. So I just wanted to, give you this list with what they mean and the descriptions, because you will be making up your mind in the next part of the survey as to what you like. Just one slide here. This is our data, but very similar data are published all over the world now. If you look at the brain connectivity as these red lines that are crisscrossing the brain, at the top here on the left is the healthy individuals, and the middle is the autism spectrum individuals, and on the right is the schizophrenia individuals. And this is the summary of that neuronal connectivity patterns. What you see here is a decreased neuronal connectivity. There is less integration between different brain regions in schizophrenia. There is too much connectivity in autism spectrum disorder, and this is the healthy individuals. So there is reason to believe that there may be an impairment in the integration of brain connectivity and integration in this illness. And the other the part of the emerging zeitgeist, if you will, the time, how times are changing, is that one of the major journals in psychiatry, Schizophrenia Bulletin, changed its name about 5 years ago to a Journal of Psychosis Spectrum Disorders. And likewise, the journal that I edit, which is another major journal in schizophrenia, which used to be called Schizophrenia Research, is now called Schizophrenia Research, a translational journal of the psychosis spectrum. So there has been that kind of a shift of mindset. And there is also the increasing evidence that is beginning to emerge that indeed dopamine is involved in this illness. And studies are beginning to show that what we call presynaptic dopamine turnover is actually increased in people with this illness. But that is whether that explains all of the illness or not, we don't know. What you see here in the cartoon on the right side is the synapse. with dopamine in those red dots. And studies do show that there is an increase in the dopamine turnover in some brain regions, like the limbic brain regions. Also, we call the ventral striatal brain regions compared to healthy individuals. So as I mentioned, Schizophrenia Bulletin has been changed in its name. Schizophrenia Research has changed its name. And DSM-5 revised the section Schizophrenia and Other Psychotic Disorders to Schizophrenia Spectrum and Other Psychotic Disorders. And the New England Journal of Medicine, which regularly publishes review articles on different diseases, has started using the term psychotic disorders and not schizophrenia in its publications. So just to summarize, the potential advantages for a new name for schizophrenia is that schizophrenia may be a new term that could potentially avoid the use of schizophrenia as an adjective. Secondly, a name change could reduce helplessness induced by a terminology like schizophrenia, the stigma induced by the term, and also potential discrimination. A new name may also stimulate public awareness and improve the image of the condition. The new name could potentially facilitate communications between patients and mental health professionals. And a new name can potentially foster new scientific advances and research models. So that's one growing viewpoint, but not everybody agrees with that. For example, Wolfgang Gabel said, so far, however, the scientific community of the Western countries has not yet come to an agreement on any alternative name. Meeting several criteria for a new name, finding agreement and among all involved groups and replacing the established term is a complex process. For now,
thank you. You too.
Can people mute themselves? Okay. For now, the concept of schizophrenia has proven its reliability, clinical utility, and validity, even though schizophrenia is a stigmatized mental disorder like many others. Renaming cannot be the only answer to negative beliefs, prejudice, and discrimination. So this author is a little bit circumspect, and that any name change has to happen cautiously and stepwise and has to be based on growing evidence. So I think that might be my last slide. In summary, the term schizophrenia has been criticized as inaccurate and stigmatizing. Secondly, several efforts are being made internationally to develop alternative names for this illness, and some professional organizations have broadened the concept to a spectrum entity. Some evidence exists that changing the name, like integration disorder, attunement disorder, may have led to more openness about diagnosis and also less stigma, although the literature is a little bit mixed still. And renaming requires careful deliberation and significant effort, but the revision is potentially well worth the effort considering the benefits in the longer run. And I just also wanted to mention that very recently there has been a large survey from Europe. Probably Raquel will say a little bit more about that. Not as large as what we have done, which she's also going to share, which also strongly pointed towards the value of potentially changing the name and the fact that the tide might be turning. So I'll stop at this point. Let me see here. And I already mentioned to you all of these names. So Raquel, you can take it from here. Tell me when I need to change my slides or move my slides.
Will do. Thanks, Cash, and thanks for that overview. So what we're going to do now is take part 2 of that survey that we started the presentation with. So you're going to rely on the background information that Cash shared, as well as the descriptions of the different alternate terms on the slide to now rate how favorably you find the different alternate terms. So if everyone can just take a couple of minutes to do that. That would be great. Give it another 30 seconds or so to complete the survey. We're hoping to get at least 75% of everyone here voting. Okay, almost at the 75% mark. Get a few more voting. All right, well, maybe given time constraints, oh, we just made the 75% mark, so we'll close it there. Okay. Interesting. I'm trying to compare how people's ratings were before Kesha's presentation and these descriptions to after. And in my bird's eye view, it looks like most of these ratings increased in terms of favorability, but we'll talk about that a little more momentarily. Vanessa, if you could pull up the second part or the last part of this survey. I think there's one more question. That would be great. Okay, so as you can see here, it says, after hearing these descriptions and getting the background that you did, do you think the term schizophrenia should be renamed? Okay, so I think we can stop there. There's obviously a clear majority who do think the term should be renamed. It may have gone up slightly from before the descriptions, but before moving on to me describing our Renaming Schizophrenia survey project a little bit more, I'm wondering maybe if a few people can just briefly share how their favorability ratings or thoughts about renaming schizophrenia may have changed after hearing a little bit more about the background and some of the descriptions of the alternate names. You can just unmute yourself and share.
I think that they're just going to be more stigmatizing unless they have a name attached to it. Like there was one that was Burring syndrome. I think to actually describe this, I mean, within the field, it's one thing, but publicly to have it called a name that actually describes brain dysfunction is not going to be helpful in terms of stigma.
Thanks for sharing that. Any other perspectives that anyone wants to briefly share?
Hi, this is Susan. And I was reading in the chat box, and I think it's important to bring it up, is that any name change should be accompanied by a public education campaign. That just the name change will probably not do it. And I'm wondering if Great Britain, I think they had a bit of a public education campaign and got not about a name change as much as how can we look at mental illness in a more balanced way and in a non-stigmatizing way. And that's just, I think the comments in the chat were saying that as well.
Right, that's a really important point, Susan, that renaming schizophrenia alone may not be enough, that there needs to be some public education accompanied by those renaming efforts. So thanks for sharing that.
I think, though, that being able to explain it as a chemical change in the brain, also would help to demystify it and destigmatize it, because then you're moving towards a medical condition rather than this idea of a mental illness. And I think people are more likely to seek treatment for medical conditions.
Great point. Thank you, Kathleen. So in the interest of time, I'm going to tell you a little bit about our survey project, and then at the end, we'll open it up to some more discussion about this. But Kesh, can you advance to the next slide?
Yes.
Thank you. Okay, so let me first start telling you a little bit about the Consumer Advisory Board and the development of our Renaming Schizophrenia survey project. I joined the Consumer Advisory Board, or CAB, at the end of 2012. And at that point, the group had been in existence for a few years. And it had been born from a wonderful initiative from the Department of Mental Health to expand engagement of people with lived experience in our research center operations. So Larry Seidman, our former director, who many of you may have known, had approached me asking if I might be interested in joining the group. Little did I know then that connecting me with this CAB group, or the CABsters, as our group often likes to be called, would turn out to be one of the greatest gifts that Larry gave me. The CAB has become an integral part of our research program. The CAB group conducts participatory mental health research with a particular emphasis on psychosis. And we approach this task with the perspectives of people who have the expertise of lived mental health experience, as well as people with clinical and research experience regarding mental health, or both, recognizing the unique strengths that each brings. This is done as a partnership in which all of our contributions are equally valued. The advantages of this partnership have truly been manifold. Our program's research has been informed and enhanced by the invaluable involvement of the CAB at all stages of the research process, including generating research questions, methodology and instrument selection, recruitment guidance, conducting research activities, data review and analysis, formulating conclusions, reviewing grant applications, and recommending dissemination strategies. In addition to this survey project on renaming schizophrenia, We also recently completed a research project on therapeutic alliance and its relationship with quality of life and serious mental illness, which had incorporated the use of 2 questionnaires that we developed, and we hope to write up our findings soon. So personally, I'll just say that this partnership with the CAB has truly made me a better, more mindful researcher, clinician, and person. This relationship has been a life-changing experience for me, and I am honored and humbled to be part of this group. And I hope that one day, all of our research will be done in collaboration with the people we're trying to serve, because frankly, that's the way it should be. So moving on to our Renaming Schizophrenia survey project, which we just completed a manuscript on, as you could see, and it represents a collaboration between everyone named on this slide, including past and present CAB members and other coordinators, trainees, and partners who have worked with our group. The CAB had started talking about this idea about 4 years ago. We were especially appreciative of Dr. Keshavan's expertise about renaming efforts around the world, including his scholarly contributions in this area. The group talked about the stigma associated with the word schizophrenia and how the name doesn't accurately describe the condition. Then we had discussed the idea of renaming schizophrenia as it was done in other countries and how we might approach that within this country. We thought that the next best step, in addition to a more thorough review of the literature, would be to survey a broad sample of community stakeholders about alternate names for schizophrenia. Stakeholders would include those with lived experience, family members, clinicians, and researchers, as well as the general public. However, at that time, our plans for the survey were put on hold as we were in the midst of another project. So in October of 2018, at the International Early Psychosis Association conference, we met again with some of our collaborators on the project to delve further into next steps for our survey. We scoured the literature for alternate names proposed by researchers, as well as new names for schizophrenia used in other countries, as Dr. Keshavan had shared before. One of our CAB members also proposed an alternate name used in our survey, which Dr. Keshavan also mentioned, and you'll hear more about shortly. And the first version of our survey had been born, which after a few more tweaks is what you took today. We launched both paper and online versions of the survey in 2019, when we also gave a presentation with one of our collaborators, Ellen Sachs, to promote and really drum up enthusiasm for our project. So as you saw, the survey included non-identifiable basic demographics, a question about whether schizophrenia should be renamed and how stigmatizing the name is, ratings of proposed alternate names for schizophrenia, as well as schizophrenia itself. And then those ratings were repeated after neutral descriptions were provided for each alternate name. And finally, although we didn't ask you to do this today, we asked for comments and feedback, including for any other potential alternate names. So you can see the most frequently used words from the comments and feedback section of the survey visually represented in the word cloud on this slide. This beautiful word cloud was created by the coordinator of our CAB group and co-author, Nicole Varga. The larger the size of the word, the more commonly it was used. And perhaps unsurprisingly, remarks on the stigma associated with the term schizophrenia appeared most frequently. So Kesh, can you move to the next slide?
Yes.
Thank you. So here are some demographic and other relevant background characteristics of the 1,190 people in our sample. While the average age was about 45, participants represented a wide age range from 11 all the way to 87 years old. Approximately 2/3 of the sample identified as female. And although the sample included a range of ethnic and racial backgrounds, the proportions of minority populations were clearly relatively small. And we definitely hope that future surveys reach out to a larger number of participants from those underrepresented backgrounds and be better balanced in terms of gender as well. So as you can see, also 25% of the sample indicated a history of psychosis. Of those with psychosis, most reported a schizophrenia spectrum diagnosis. And a similar pattern was reported by family members, with the majority reporting having relatives with a schizophrenia spectrum diagnosis as well. Of the stakeholder groups surveyed, respondents most frequently identified as family members of people with mental illness, followed by mental health providers, and then by those having lived experience of mental illness. Psychologists comprise the majority of mental health providers, though there was also meaningful representation from other types of clinicians, including social workers, psychiatrists, and peer specialists. Kesh, can you move to the next slide? Okay, so here's what we found. First, the majority of survey respondents favored a name change for schizophrenia. I should note that the 74% listed here is after the alternative names were given. Before it was still a majority, but it was 69%. Another important finding is that the majority of respondents found the name schizophrenia stigmatizing. So on a Likert scale of 1 to 5, about 71% of responses were either scored as 4, somewhat stigmatizing, or 5, very stigmatizing. The mean rating was about 4. And of the proposed alternative terms, altered perception syndrome emerged as the most favored term after the descriptions were given, followed by psychosis spectrum syndrome and neuro-emotional integration disorder. The least favored terms, aside from schizophrenia, were Bleuler syndrome and salience syndrome. I want to point out again that altered perception syndrome is a term coined by a member of our consumer advisory board who has lived experience with schizophrenia, Linda Larson. It is the one term that has not been used as an alternative name for schizophrenia in the literature or in other countries. And it wasn't just the highest rated term across the entire sample, but within each stakeholder group. So from our perspective, the popularity of this one term coined by someone with lived experience highlights how imperative it is to include the ideas and opinions of those living with a disorder in all renaming efforts. I also want to point out, which you can hopefully tell from the graph, that after descriptions for the alternative terms were given, support for renaming schizophrenia increased significantly, as did favorability ratings for the alternative terms. So by describing the terms, they may have become more accessible and better understood. It also may suggest that a name change could best decrease stigma and increase knowledge of the disorder when accompanied by initiatives to educate the public. And obviously, a few of you have already brought that up. The bars that are all the way to the right are for schizophrenia, which was the only term that was rated less favorably the second time it was rated. And finally, while most respondents favored a name change and expressed hope that a name change would reduce stigma and discrimination and better represent characteristics of the condition, there were some who didn't agree, like Dr. Keshavan mentioned before. A subset of survey comments expressed that simply changing the name would be ineffective and that any name would become stigmatized over time. Instead, they called for public education about the term. Other commenters called for more scientific research before accepting a name change. Others brought up concerns about diagnostic criteria confusion, loss of disability payments and insurance coverage, and a lack of suitable alternative terms. We also did get a few interesting alternative terms in the comment section. So things like perceptual integration disorder, reality integration disorder, altered thought and perception syndrome, and that term was coined by another one of our CAB members, Charles Strommeyer, who you'll be hearing from a little later today. So with that overview about our survey and its findings, I want to briefly turn it back over to Dr. Keshavan to share some implications for how to talk to people with a newly diagnosed psychosis, and then we'll hear from members of our Consumer Advisory Board for their reflections. So, Kesh?
Yeah, thank you, Raquel. That was a very nice review of the study and also the results, which were interestingly very much mirrored by this group. The same kind of a priority for choosing terms like altered perception syndrome and the psychosis spectrum disorders were very similar to what we saw in our survey. What we saw in this group mirrors what we saw in the larger survey, which is really reassuring. In some ways, this is kind of a mini replication, if you will, of our study. So that said, one important observation that did stand out both in our survey and in this little exercise that we did today, and that is that the proportion of people preferring alternate names went up, and the proportion of people preferring the term schizophrenia went down after a brief education, which really emphasizes the point I think Susan Gingrich, that education campaign might be the way to go. We need two things now. We need more research to really understand this illness, so that we have a name that actually accurately reflects what we are treating. But also we need a name that is free of any possibility of being used as adjectives. And some people do argue that whatever name you give to a disorder, it gets stigmatized down the road and so on. That has not consistently happened like that in the rest of medicine. For example, when the term was used for tuberculosis as consumption, it was a lot more stigmatized. When the term was used, which was based on the Mycobacterium tuberculosis germ, the stigma went down. So there may be something to the use of a term that takes the blame away from the individual, but towards a system, a circuitry in the brain, for example. So something to think about. Now, given all that, we are at a point in the history of our field that we could be rethinking about how we do our usual business of talking to our patients. And here is an opportunity. And over the period of my own career, I have heard stories innumerable times of patients and families saying their doctor told them, you have you will never get better. You will never have to go off medication. You will never be able to work. You will, and so on. These are terms that psychiatrists and other clinicians have used in describing the diagnosis when they had their loved one had a first psychotic episode and so on. That really is not necessary. And I think we can turn a new leaf in how we talk to our patients about the diagnosis. In the first psychotic episode, or in the aftermath of an initial psychotic illness, is an opportunity to set it right. An opportunity to help the individuals with the illness to get an understanding as to what is the nature of the problem and what is the outlook for down the road. So in other words, what is the diagnosis and what is the prognosis and so on. In the rest of medicine, there has been quite a bit of literature on how to talk to our patients about diagnoses. There is quite a bit in the cancer world, and but not as much in the psychiatry world. So there are some basic principles to be considered and kept in mind when we begin to have that conversation about the diagnosis with patients who have been in the early course of their psychotic illness when they don't know what has been happening. So I summarized those principles in the form of a little acronym, which people who know me well know that I have a little thing for acronyms. For my own simple mind, I create some acronyms which will then be useful in remembering things. So this is called the Inspires acronym. It stands for the 8 principles that are useful in talking about diagnosis with people with the newly diagnosed psychotic illness. First of all, we need to individualize what we say to patients, because not everybody has the same kind of a background. Some have already learned a little bit about what their diagnosis is, maybe from Google or maybe from their previous clinicians and so on. We need to know what they know or what they don't know, so that we can individualize our approach to presenting the information. And there are also individual differences as to how people will respond to new information. The second thing is, as much as possible, we should normalize what we say to the patients. For example, when you are using terms like paranoid thoughts, it's probably a lot more judgmental term, and it's a lot more loaded compared to saying simply, instead of saying, you're having symptoms like paranoid thoughts, you can say, you are having difficulties in trusting others, which you have been experiencing, and so on. So these are ways to normalize the different symptoms. Everything that we see in psychosis are in smaller ways potentially experienced by individuals in day-to-day lives. So that helps reducing stigma. The third thing is, consider the setting in which you provide the information. It's important to have a safe setting, ensure confidentiality while having a conversation. In some cultures, it is expected that family is present during such conversation. May not necessarily always be the case, but in a young person with a newly diagnosed psychotic illness, it's important to talk to the family members with or without the individual with the illness present. And of course, you have to determine individually how you go about that. The fourth point is getting the perspective. The patient and family may have a perspective on the nature of the illness that is different from the clinician. Some patients come to us straight off with an anti-medical model bias. You don't want to straight off get into a loggerheads with them and get into a debate. It's first find out what their perspective is, and then find a point of agreement, even though he or the family and you or the patient and you may not agree about a particular diagnostic label. You may have to have an agreement on what the symptoms are. You could start off with that. And then the fifth point is information. Our duty is to provide accurate and information that can be processed. So while having the conversation about the diagnosis, it's important to have the accurate information handy. Any previous medical records, any test results, any neuropsych test results, collateral information, as much as possible, so that you have the knowledge at your fingertips. And sometimes, and in fact in psychiatry frequently, the information is just not available. So the specific diagnosis may be unclear. And it's okay to share uncertainty. You can say, your symptoms appear to suggest that you have a condition which we call a psychotic syndrome, but we don't know everything, and time will tell us. So that would be the kind of approach to take. Uncertainty is is acceptable, and honest sharing of uncertainty, and also the honest sharing of the variability in outcomes is also important. The sixth point is people with psychotic illnesses and their families are frightened. They have seen something very, very unusual, and they don't understand it. They're panicked, and they may not understand everything you say. They may not remember everything you say. So repetition is helpful. Providing information cannot be a one-time, one-session deal. It may have to happen over multiple sessions. Always open time for answering questions, respond, reassure, and always instill hope. And I find myself often talking to family members where and patients with psychotic illnesses to say that these are illnesses that have their worst at the early part, and over the course of time, usually things get better, which is the case. You're not looking at someone who has a neurodegenerative diseases or a muscular dystrophy or something like that. So fortunately, in most psychiatric disorders, the outcomes are chronic, can be self-limiting, but it's very rarely progressively degenerating. So providing hope is very, very helpful, very important. Looking at the optimistic aspects of things. Always exercising empathy towards the patient and family members' emotional responses, ensuring that they feel listened to and understood, identify and acknowledge their emotions, and address them in a helpful manner. For example, it may be upsetting to hear this diagnosis, not the one you probably wanted to hear, but you're in the right place at the right time for treatment, and so on. Always present the positive aspect as well as the challenging part. And finally, you would never want to close that conversation without pointing out the next steps. A diagnosis is better accepted by patients and families if presented as part of a management plan. That's critical, as a way of providing a basis for next steps, interventions, provide information on all available treatments and outcomes, and local availability of resources, actionable next steps. So those are the key points that I would say are helpful in conveying diagnosis. So whether we use the term schizophrenia at the beginning or not is a matter of individualized decision. I typically don't use the term schizophrenia very early because very often I'm not sure. I convey that uncertainty and I say time will help. I spend more time explaining to them about the nature of symptoms. And then if a diagnostic decision is required and if patients and families want it, the term psychotic disorder is a good initial step as a way of helping them understand what they're going through. The term schizophrenia, at this time, we still don't have very good alternatives. Today's discussion has suggested that we may have ways going forward of making it easier and more comfortable for clinicians to share diagnosis. Alternative terms might become the way we practice psychiatry going forward, but it's not there yet. We still need the term schizophrenia because DSM still has it, our billing codes still have it. So we currently have to live with it for now. I'll stop there. And I know there is quite a bit of the agenda still. Thank you.
Right, thanks, Cash, for that summary and guidance, given what we know about the term and some alternative terms for schizophrenia as well, and the best ways to communicate with people who have been newly diagnosed as well as family members. So what I'd like to do is, actually, if we can move to the next slide, Cash, I just want to introduce 3 members of the Consumer Advisory Board to share very briefly some of their reflections about all of this as well. So first, I'd like to introduce Charles Strommeyer. Charles works in equities investing, advising startup companies, and doing research in artificial intelligence. He has helped with pioneering multiple new software markets such as AI-based digital marketing, the intercloud, and deep learning-based software coding assistance. I don't even know if I understand all of that, but very impressive. And the startups he helped has raised more than $2.5 billion in funding. Due to his efforts, he was awarded the Developmental Commonwealth Innovation Award. Charles's hobbies include music, movies, and neurobiology, and he especially enjoys mentoring young people, including 14 people in the Forbes 30 under 30 list. So with that, Charles, take it away.
Thanks, Raquel. And thank you everyone for coming to our talk. Can you hear and see me? Okay.
Yes. So I can stop the slides for now. Can go back. There's one more slide left at the end. We can come back to so people can see each other better. Yeah.
Okay, so I joined the CAB 2 years ago when the naming project was partway through. But I had previously thought about the nosology or classification of psychosis because I have lived experience and I was once diagnosed with schizoaffective disorder. This remains a controversial diagnosis. But recently I was thinking more about it, and a guy with bipolar once asked me, "Are you bipolar?" And I said, "No, I'm in between," meaning in between schizophrenia and bipolar, even though most experts and researchers classify schizoaffective disorder as a schizophrenia spectrum disorder. But there's a new paper in JAMA Psychiatry led by Christina Lundquist, and they invent a new novel metric called family genetic risk scores and apply it to the entire Swedish population over multiple decades. And they find out my intuition was right. Schizoaffective disorder is a stable diagnostic category in between bipolar and schizophrenia. And then after I joined the CAB, I looked for other work on renaming schizophrenia. And I found a 2019 paper in the British Journal of Psychology Bulletin. It's a study of Twitter usage, and it found that the terms psychosis and psychotic had many more negative connotations on Twitter around them than the terms schizophrenia and schizophrenic. So I thought maybe a new name should be more bland, perhaps like Kesh likes an acronym, like ADHD is an acronym, or PTSD or ASD. The first acronym I came up with was PNSD, which is positive and negative symptoms disorder, but lay people don't know what these symptom categories are, so they might think it's bipolar disorder. So I'm not in favor of that. And then regarding the other names, attunement disorder, integration disorder, and neuro-emotional integration disorder don't seem specific to schizophrenia. For example, they might describe autism spectrum disorder. Disconnectivity syndrome for lay people might imply disconnected from reality, whereas experts wouldn't know if it means disconnected synapses or disconnectivity of white matter. Dopamine dysregulation is not specific to schizophrenia. It also occurs in Parkinson's disease and addiction. And to answer a question posed by Kesh, another new paper in JAMA Psychiatry shows that symptom severity in schizophrenia is linked to glutamate levels. Glutamate's the most common excitatory neurotransmitter in mammals, so it's not just dopamine. The problem with salience is what is salient in terms of the mind of most people. It would be confusing. The two names I like most would be Bloyler's spectrum. So it'd be named after a physician, kind of like Alzheimer's disease, and also altered perception syndrome, but that might not be specific to schizophrenia. And some people might think perception only refers to sensory perception, whereas I like to think of it as perception of one's own thoughts too. Now, a variation of an acronym of this might be best. For instance, I would describe myself as altered thought and mood spectrum or syndrome. So that would be ATMS. But generally, I like the idea of a bland acronym. for a possible new name for schizophrenia. Thanks.
Thank you so much, Charles, for sharing your perspectives on this. Let me move on now to Nate Schwerian, another one of our CAB members. Nate has an interdisciplinary Bachelor of Arts degree from UMass Amherst and an Associates of Science degree in Biotechnology from Mass Bay Community College. He currently works with Tunefoolery Music, which is a group of musicians in mental health recovery, where he works as an audio technician, performer, and meditation group facilitator. So, Nate?
Okay, so I'll present some of what we did within our group, but first, a little bit of my personal background. I've personally lived through some of the experiences of this condition and experienced some delusions and hallucinations. And in treatment of this condition, I've experienced difficult side effects from dopamine blocking medications. And so I'll get to that in a minute. That's an issue that I have with that name. These experiences have influenced my part in the discussions our group had about the subject. And with my own experience of the names that are listed, altered perception syndrome seems to convey some of the experiences of a diagnosis like this. To me, it seems to accurately convey some of the experiences that I've been through. So during the course of our work, we looked at materials about other potential names from papers from places where they've already renamed schizophrenia. We discussed why a name may be beneficial or why it might not be good. For example, a medical description of the condition might reduce stigma, but it might reflect an incomplete understanding of the disorder and limit some potential research into the condition. We talked about how it might be beneficial for a new name to help people understand what the condition is. We discussed how words like syndrome and spectrum might be good to help reflect that not everyone with this illness has the same condition. There was some discussion about how some names from other countries might not translate well into English to help provide understanding of the condition. And other names included in the word psychosis, which was also felt by some to be a stigmatizing word, partly, again, because similar to schizophrenia, it's poorly understood by people who do not have a clinical understanding of the word. There was some discussion about whether the name even should be changed. Some reasons for considering the change were to reduce stigma and to help promote understanding of the condition. The term isn't as well understood by people who don't use the word professionally. So this possibly might be more relevant to people who don't use the word professionally because they're not as familiar with what it means. So some of our thoughts from these discussions we submitted for a paper that was being written, and our thoughts were being edited into the discussion section of the paper, and that will be submitted soon for potential publication. So some specific thoughts that I had on dopamine dysregulation disorder. One thing that I do like about it is that it's an attempt to describe the condition medically, which I do think could reduce stigma, but there are several things that I don't like about it. One of them being that blocking dopamine can cause severe side effects. Another being that it might not always be dopamine. An example of this possibly is that clozapine has lower affinity for dopamine receptors, yet for some people it's a more effective medication. So that might indicate that it's not necessarily exactly dopamine, although dopamine does have some effects, and it's so far what is known for treatment. But that goes to the next point, that naming it a dysregulation of dopamine, I think, could limit research about how other neurotransmitters are involved in the condition. And I wouldn't want a name to get research stuck on this idea that it is just dopamine, when the brain is very complex and there are a lot of neurotransmitters involved, and there may be potential for other types of treatment. So I had some concern that a name could possibly limit research possibilities. So in the group, we discussed some general good things that we thought were good about a name and bad about it, or pros and cons about various names. And so I was going to just generally go over some general things that seem to be considered favorable or unfavorable in our discussions in the group. So things that were generally considered favorable were whether the name was descriptive, whether it was easy for the general public to understand. So if it helps explain what it is to non-experts, if it reduces stigma. A more medical name was thought that could possibly reduce stigma. Spectrum and syndrome were thought that it can show that there is a variety within the diagnosis. And another beneficial characteristic of some of these is that it might help explain the condition. Things that were thought to count against a name in our discussion were if the name didn't describe the condition. Another thing is that a medical name could limit research because full medical understanding is not yet known. There's a lot more research needed before this could really be specifically described medically. And another thing was that the meaning might not be clearly understood. Another thought was that a new word could be stigmatizing, and that was a thought about psychosis spectrum disorder, is that, again, the word psychosis is, to the general public, it's not similar to schizophrenia, it's not so well understood, although professionals do know what it means, but for the public it may be difficult. And then another thing that might count against it is that it might not be specific enough to schizophrenia. And that's all I have for you. So thank you.
Great. Thank you so much, Nate, for sharing that as well. And then Dan Johnson, another member of our Consumer Advisory Board, was just going to very briefly in a minute, since we're running short on time, just share a few more thoughts. Dan is a writer and a peer specialist at the Edinburgh Center in Massachusetts. He's a graduate of UMass Lowell in creative writing, and he's written and spoken publicly about his lived experience for years to advocate for early awareness and treatment of psychosis. Dan continues to explore how stories inspire hope and galvanize resilience through providing peer support as a member of the CAB and as a fellow of Yale University's Lived Experience Transformational Leadership Academy, Let's Lead. Along with peer support, writing, and speaking, he's been known to play music, to find rocks to climb, and to cook and eat food. Dan?
There you go. Yeah, so I'll fly through. Thank you very much, Raquel. Thanks, Nate and Charles and Kesh. And I'll basically just mention that at the heart of both peer support and of this project is the idea of experience-based and person-centered language, which brings the focus onto the individual and each of our own experiences. Often in peer support, we won't use terms such as any diagnostic terms, and in listening to what some people or what people are talking about their own experience gives them the opportunity to construct their own narrative, and come to their own understandings of their experiences, many times which they haven't had the opportunity to do before. Being in the system and hearing terms like schizophrenia applied to them in a way that accentuates stigma and discrimination. I'll just end with that, a rose by any other name would smell as sweet, I suppose, but we're not talking about roses. We're talking about language that can be used to harm people, to discriminate. And I think that like even opening up the conversation as we're doing today is a movement forward, and we'll get there.
Wonderful. Thank you, Dan, and also Charles and Nate for sharing your extremely important perspectives on the whole process and just the whole idea of renaming schizophrenia. Ellen, since you were also a big part of pulling this together, I was wondering if you wanted to just very briefly share any of your perspectives on this. You're still there.
Do you want to introduce Ellen just quickly? I mean, she doesn't need introduction, but I think if you could say, Ellen is well known for her advocacy, and her book, The Center Cannot Hold, is a landmark volume on the experience of mental illness and how we can move forward with mental health advocacy. Ellen.
Ellen may be having difficulty unmuting, I'm afraid.
Oh, I see. Okay.
Well, thank you. Well, Steve, you are also an important part of this process.
Yeah.
Can you hear me now?
Yes.
You can hear me now.
Yeah.
Excellent. Well, thank you. Thank you so much for both this research and this meeting. I think the study itself and the talks today were really important and really compelling. So we don't have people just sitting down and saying, well, here are some names, what do we like best? But we're having an actual large-scale empirical study that looks at different stakeholders and their points of view, and also looks at different possible names. I think names mean a lot, and they've already changed a lot in the mental health sphere. So we used to talk about Looney Tunes and nutcakes and crazies. A friend of mine, he unfortunately passed away, Fred Fries, was a psychologist with schizophrenia, and he used to say, please don't use the N word to refer to us. In other words, nuts. And obviously in other contexts in our society today, we're thinking about names, and names that stigmatize and names that hurt, and we want to, so it's part of a larger cultural thing to be thinking about names. It's also pointed out that some people, when they hear the word schizophrenia, feel no hope. In fact, when I broke down, I had to do an interview to get back to Yale Law School, and the doctor said, why don't you take a couple of years and get your occupational feet wet and work, as a cashier or something. And I thought, I've been a student all my life. I like it. I'm good at it. The hours are flexible. How much more stressful would it be to have a line of people demanding change? So it's not one size fits all. And I think, when we think about names, as was just kind of suggested, there are different vectors in which to consider it. So is the word descriptively accurate? Is it stigmatizing? What do we do if it's both at the same time? Which should trump? And I think it's also very important, as we have today, to focus on the consumer point of view. We're the ones being referred to. So if there's diversity or difference in a study where parents want this and patients want that, I think patients in this question should really trump. And my own preference, I think, is like Alzheimer's, how about Bloiler syndrome or Kreplin syndrome or something like that? Or maybe altered perception and thought difficulties or disorder. That might be okay. APTD, that will be our new acronym. So again, thank you so much for doing this project and inviting me to be part of it. And as we say at USC, fight on. Thank you.
Wonderful. Thank you so much, Ellen, for sharing your perspectives as well, and realizing we're out of time already, but I don't know if Kelsey, you just wanted to provide some closing housekeeping remarks about today's presentation, and Kesh, she might need the slides back up for that.
Sure, thank you. I think the only last points, so there are a few other upcoming events. So thank you all so much for showing up here, and you can find more future things on the MHTTC website, which you can see here. And as a reminder, you'll receive an evaluation via email after this course. Please fill that out, especially if you're looking for CEU credits. But yeah, I think that is everything we have today. So we'll leave it there. Thanks, everyone.